A very good morning to all. I'd like to congratulate the Department of ORL in UITM for organizing this long overdue conference and the participants for taking the time to join us today. The topic I'll be presenting is a subject very close to my heart, which is persistent postural-perceptual dizziness. What is this PPPD? Let us begin with a patient of mine. I would like you to take a note of the pertinent history and think of what could be her possible diagnosis. We have here a 42-year-old lady with history of hypertension, chronic anemia, presenting with history of feeling imbalanced for the last 4 months. Occurs daily and she feels it when she is standing or walking. She feels better sitting or lying down. It started with her having been treated for severe vertigo, which lasted for 2 days. She had seen her ENT then and was diagnosed with vestibular neuritis. The vertigo was resolved, but she still feels like she's floating on a boat. She has stopped working because of her condition. So what are your thoughts? Obviously, given her history, I would like to know how is her blood pressure, especially in the last 4 months. Any change in medications? Is she having any symptoms now? And if yes, what is her BP in the clinic? I would do a sitting and standing BP while I'm at it. Then, of course, we would like to know more about her anemia. Any other symptoms of anemia? What is her most recent hemoglobin levels, preferably within the last 4 months? Then I would ask if the current symptoms are similar to what she had initially. Has the true vertigo resolved or is it episodic? Could she be having Meniere's or recurrent BPPV? Could it be other medical conditions? How are her sugar levels? Are the symptoms related to meals? Does she have palpitations or chest discomforts? Any other focal neurological symptoms? If the history and prior investigations have ruled out other possible or sinister diagnoses, we may be having a case of PPPD. Like it or not, we do get patients like this in our clinics. Once we have excluded other medical illnesses that may cause this, we start to dissect the vestibular aspect of the illness. My presentation today will consist of understanding the diagnostic criteria, followed by looking at the PPPD in our population and the treatment options. To arrive at the diagnosis, we need to learn the diagnostic criteria. A little background story about PPPD. It is believed that as early as 1870, which is 130 years ago, in Germany, there were cases of patients being afraid to leave their homes, afraid of crowds, afraid of going to the market, fear of the marketplace, which is translated into German as agoraphobia. However, in the patients, they could actually just be having problems with balance, and having to go out to a crowded place with so much visual stimuli will make their symptoms worse. This diagnosis was of course made by a psychiatrist, as neuroautology only came about 70 or 80 years later. 100 years later then, more and more autologists and ENT experts began to see patients with imbalance and dizziness, and we started hearing terms like phobic postural vertigo, space motion discomfort, visual vertigo, which later became visual-induced dizziness, and then chronic subjective dizziness. All these conditions have slight differences but had more overlapping similarities than differences. In 2017, the Bereni Society proposed a condition called persistent postural-perceptual dizziness, or PPPD. They felt that all these patients who may have had CSD or PPV or SMD were actually having the same condition, which is PPPD. In PPPD, there are 5 criteria. We begin with A, which is one or more symptoms of dizziness, unsteadiness, or non-spinning vertigo on most days for at least 3 months. Symptoms last for prolonged periods of time but may wax and wane in severity. Symptoms need not be present continuously or throughout the entire day. Persistent symptoms occur without specific provocation, but are exacerbated by 3 factors: upright posture, active or passive motion without regard to direction or position, and exposure to moving visual stimuli or complex visual patterns. The disorder is triggered by events that cause vertigo, unsteadiness, dizziness, or problems with balance, including acute, episodic, or chronic vestibular syndromes, other neurological or medical illnesses, and psychological distress. When triggered by an acute or episodic precipitant, symptoms settle into a pattern or criterion A as the precipitant dissolves, but may occur intermittently at first and then consolidate into a persistent course. When triggered by a chronic precipitant, symptoms may develop slowly at first and worsen gradually. The fourth criteria includes symptoms must cause significant distress or functional impairment. And lastly, symptoms are no better accounted for by any other disease or disorder. PPPD is now recognized by the World Health Organization or WHO and has been included in the 11th edition of International Classification of Diseases. It basically translates to persistent non-vertiginous dizziness, unsteadiness, and non-spinning vertigo that is exacerbated by postural challenges and perceptual sensitivity to space motion stimuli lasting for more than 3 months. To put it simply, PPPD patients has the feeling of imbalance when they are standing or walking, which are made worse if they are in a crowded place or a location with lots of movement. These symptoms would have to be ongoing for more than 3 months. PPPD onset may occur after a vertiginous event such as BPPV, panic attacks, concussion, or autonomic disorders. Once the acute vertigo fades, PPPD patients complain of dizziness, described as feeling lightheaded, floating, or head fullness with unsteadiness, and feeling as if veering from side to side when walking. Symptoms persist for most days. Categorized as a chronic functional vestibular disorder, PPPD is now the most common cause of chronic dizziness in the middle-aged, with incidence peak between 30 to 50 years. To understand the pathophysiology of PPPD, I have come up with this pictograph. We start with a person who suffers from an acute dizzy attack. Imagine yourself having food poisoning or a very bad cold. You are dizzy, you may even experience vertigo. Because of this horrible disorientating feeling, we will all choose to just lie in bed. But what if you want to get up? What do you do next? It's what we call acute adaptation, which involves visual dependence, where you use your sight to find a fixation point, a stable point to achieve some stability. We then need to get up to the toilet to throw up maybe, and to prevent from falling down, we increase our postural control. Our neck muscle stiffens to prevent sudden head movements, which may make us feel more ill. Our hands reach out to touch or grab whatever is nearby to lend support. Our brain goes into hyperdrive with increased environmental vigilance. We are conscious of what is around us, what is moving. Once the acute vertigo resolves and we feel better, we undergo normal readaptation and recover with no residual symptoms. However, not everyone recovers. Some, especially those with anxiety-related personality, go into high levels of anxiety and vigilance. They sustain their visual dependence, postural control strategies continue, and there is reduced cortical integration of spatial orientation and threat assessment networks. How we know this is through functional MRIs. Studies have shown that visual cortex anxiety centers are increased in activity much more than normal controls. So because they have these sustaining mechanisms, they fail to readapt, and we call this maladaptation. With time, PPPD patients will also complain of eye tiredness, especially at the end of the day, neck stiffness and headaches, fear of falling down, even though their vertigo is no longer there. These symptoms then feed into an already heightened anxiety levels, and they are stuck in a vicious cycle. Can they come out of it? Numerous studies have since shown that PPPD interferes with the daily life, as well as the way individuals experience their personal, social, and work life in presence of chronic conditions. Dizziness or vertigo is a burden to the patient as well as the healthcare services. Because of dizziness, 69.8% of working adults had reduced their workload. 63.3% had lost their working days, 4.6% had changed their jobs, 5.7% had quit their jobs, and these patients have had between 1 to 4 visits to the emergency services, primary care services, or specialist consultants prior to getting a diagnosis. Some had hospitalization ranging between 2 to 7 days. Hence, getting the right diagnosis to start the right treatment is crucial. So how does PPPD affect our population? In Hospital Sungai Buloh, between August 2019 until June 2021, 30 patients were diagnosed with PPPD. The numbers were expected to be more but not captured as Hospital Sungai Buloh is a full COVID hospital. Clinics were closed or reduced to neuro referrals. We also had patients who were just afraid to come to a COVID hospital. Of all these 30, some were from UITM referrals. Our local PPPD patients were no different from the published demographic data of being predominantly middle-aged with mean age of 45.4 and females with 63% making the study population. Main symptoms consist of unsteadiness, followed by dizziness and a few with headaches. They all had neck stiffness or neck pain and eye tiredness worse in the evenings. Majority had been suffering with the illness between 1 to 5 years, followed by nearly a quarter having the symptoms for more than 5 years, not knowing what was wrong with them. Majority had symptoms nearly daily and were triggered by movement followed by visual stimuli and lack of sleep. 13% were of primary PPPD, meaning no precipitating episode of an acute vestibular event was seen or noted. Those with secondary PPPD were mainly caused by BPPV, followed by vestibular neuritis and strokes. There were no significant findings in the vestibular assessment of the PPPD patients, and this was similarly seen in other published data. We then compared our patients with PPPD with those who had recovered from the acute vestibular symptoms, and they were put under the control group. We assessed our patients' quality of life using the Eurocall EQ5D visual analog score, the dizziness severity using the DHI or Dizziness Handicap Inventory, and mental health assessment was based on the DASS or DAS-21. The quality of life in PPPD patients was significantly affected with a 20-point drop based on the EQ5D quality of life VAS scores of 88.3 in the control group to 67.9 in the PPPD group. Hebs and colleague had conducted similar comparison and also found a 20-point drop in the EQ5D from 78 points to 58 points. It was interesting to note that while most of the dimensions in the EQ5D of our PPPD patients were affected, self-care was spared. The DHI in PPPD had a mean of 48.3. This fell within the documented range of 44.5 to 59.8 in recent literature. This was significantly higher than in controls, which had a mean of 19.1, and this further supports the findings of those in literature. It is not surprising that PPPD is predisposed in patients with anxiety or depression, and this was seen in our study population with significantly higher scores in depression, anxiety, and stress when compared with the compared control group. The mean value for depression was 6, which was placed it as mild, anxiety was 8 at moderate, and stress at 7.5 in mild. These values do not characterize them as having depression or anxiety disorders, as the values are borderline. However, they certainly demonstrate traits of anxiety and with greater tendencies for depressed mood. Looking at the effects of disease duration on PPPD patients, our study has shown increased anxiety levels among those who had PPPD for more than 1 year. And this was accompanied by a significant increase in physical handicap due to the dizziness. While it is now established that anxiety mood predisposes one to PPPD, It is worrying that our findings have discovered that having triple PD for more than a year worsens the mental health, especially anxiety. This may lock the triple PD patient in a vicious never-ending cycle, where having anxiety predisposes one to triple PD and untreated triple PD worsens the anxiety. Interestingly, the triple PD patients did not note any significant drop in overall health quality nor overall DHI scores with increased disease duration. There were also no significant effects on the depression or stress levels. Thus, it is safe to state that anxiety increases the risk of triple PD, and if triple PD is left untreated, it will heighten the anxiety levels and perpetuate the condition while it may not increase the intensity. I would like to highlight that it is possible that the reason for the chronicity is the delay of diagnosis. Caesar et al. Reported their triple PD patients had lost confidence or trust in their health professionals, with some being aloof or unable to provide them with answers or cure. While the patients did not necessarily expect healthcare professionals to have all the answers, they wanted validation for the invisible and unidentifiable condition. This is where it's important for healthcare providers to build and sustain a stable therapeutic relationship tailored to the individual triple PD patients while providing validation to prevent self-stigmatization. Treatment starts with communicating the diagnosis in functional disorders such as triple PD. An informed understanding of the underlying mechanisms is crucial, more so than for most structural disorders. This is usually performed in a calm, unrushing setting. I make sure my room is quiet, and even the clothing I choose to wear on my vestibular clinic day is of non-busy design. We want to reduce as much visual stimuli as possible before they begin their treatment. Once patient shows understanding and confidence in the diagnosis, further treatment strategies should be explained and initiated for triple PD. Vestibular rehabilitation is a range of physical treatments that aim to compensate or retune impaired balance control. A wide range of exercises can be used in vestibular rehabilitation, which will be presented by our highly experienced physiotherapists today, and I will not elaborate further. However, in triple PD, rehab may vary from general and natural exercises such as walking programs with gradual build-up of brisk walks up to 30 minutes to more specific dizzy, provoking head movements which should be performed relatively slowly. Patients should be encouraged to become more aware of any dizziness, but at the same time remain calm about it and persist with the exercises. I usually remind them that for one to feel dizzy, it means the vestibular organ is still functioning, and that is a good thing. Taper down the exercise if it's making them too sick, but increase if their tolerance is improving. Empower your patients to take charge. Choose activities which they may enjoy. For one patient, I prescribed playing with her cats as therapy. At her 1-month appointment, she reported feeling much better and her cats were happy too. Among our triple PD patients, 82.6% reported improvement after starting vestibular rehab. After 3 months of vestibular rehab therapy or VRT, there was significant improvement in mobility, anxiety and depression, and overall quality of life scores, DHI scores, and stress levels. A few studies specifically on patients with triple PD have been published. More than 50% improved with VRT alone. Posturography, which have abnormalities in 79% of cases, dropped to 33% post-treatment in other studies. Among my patients, they were recruited in a randomized control trial, and we compared between hospital and home VRT. For home vestibular rehab therapy, we use Balex, which we are lucky to have the creator among our speakers today, Dr. Zuraida Zainun, who is also my SIFU. Results so far show that our triple PD patients significantly improve in the quality of life, DHI, and mental health with VRT. When we compared individual arms, there was no difference between either methods in the rate of improvement and the rate of improvement between first month and third month after starting therapy. This means that, especially now with COVID-19, we can start therapy at home and is as effective as coming to hospital for rehab. Third part of treatment is cognitive behavioral therapy, or CBT. Hospital Sungai Buloh has a team from psychiatry and psychology counselors who are trained for this. CBT provides guided self-observation on physical, emotional, and psychosocial levels, and is the first step towards breaking out of the maladaptive cognitive behavioral cycles. I've encountered patients who are hesitant to get a formal appointment with the psychiatrist and are more open to seeing a counselor. Take the time to earn the trust of your patient and don't force them into any treatment they are not ready for. For those who are not ready, I sometimes recommend mindfulness exercises. Many of my patients who have undergone CBT report back that the therapy helps with managing the anxiety and helps especially with work stress. Several trials involving CBT in PPPD have shown to be effective. Compared to the exercise-only group or sertraline anxiolytics alone, CBT-treated patients had significantly greater improvement in experience handicap, anxiety, and depression. Selective serotonin reuptake inhibitors, SSRI, and serotonin norepinephrine reuptake inhibitors, SNRI, are commonly recommended for chronic functional dizziness, with or without psychiatric comorbidities. Different agents have been studied, and these studies suggest that SSRIs or SNRIs can be useful treatment options in patients with PPPD. Since rehabilitation from PPPD relies on readaptation of vestibular and balance control systems, vestibular suppressant drugs such as antihistamines and benzodiazepines can be expected to delay rather than help with rehabilitation and should be avoided if possible. A tip: if the DAS scores are severe and above, or the patients are crying outwardly in the clinic, I would offer referrals to the psychiatrist. Many are so desperate that they welcome the suggestion. PPPD often requires multidisciplinary team efforts, such as from the audiologists, physiotherapists, neurologists, and of course the psychiatrists. To recap on PPPD and what to do when we meet a patient who may have PPPD. A Malaysian study in 2017 showed an average consultation duration in the public outpatient clinic was 18.21 minutes, ranging from 2 to 75 minutes. Based on our experience, the average 18 minutes is definitely not enough to work up a patient and derive a diagnosis, especially in a patient with chronic dizziness, especially with good history taking. To derive the correct diagnosis, accurate history is utmost important. When approaching chronic dizziness, current symptoms are often focused, but it's more important to know the history during the first onset of illness and the progression of symptoms. It is helpful to dissect the secondary symptoms which have developed over the time from the offending pathology. Symptoms such as muscular pain, neck stiffness, eye strain, and fatigue, especially at the end of the day, which are due to visual dependence and postural control mechanisms, can sometimes create confusion in making the etiological diagnosis. Where does PPPD stand out in this sea of chronic dizziness diagnosis? PPPD has its distinct diagnostic criteria. Often in our clinic, PPPD patients have a palpable relief upon hearing that their symptoms were not imagined and instead verified, as a diagnostic criteria is so clear and so familiar to them. This pictograph describes it all. A patient with chronic dizziness precipitated by an acute vestibular event enters into a state of high-risk postural control strategies with visual dependence and increased environmental vigilance, develops further fear of falling, health anxiety, and avoidance of anything which may proceed with a fall. They then get stuck in a vicious cycle of overcompensatory movements, phobic self-observation, resulting in gait disorders and neck stiffness. We need to get them out of this. The first step is patient information through education. Then, together with individualized vestibular rehabilitation, physiotherapy, CBT, and medications if required, we can help them. I hope this lecture was insightful, as it was a rather new condition. I welcome any questions, or you may email me at the email address. Thank you.